Audible, but there are a lot of echo. So please check that echoing, so much echoing is there.
A very good afternoon to one and all. Present here, we warmly welcome to the most awaited CME on respectful abortion care. This CME is organized by Department of Obstetrics and Gynecology, BLD, deemed to be university, in collaboration with WHO, FOXC, and Vox, and Alamin Medical College. Unsafe abortion is a significant public health problem and important cause of maternal mortality. Today's CME is in hope to further enlighten about respectful abortion care. Ultimately, it is to ensure that we provide safe, quality, and comprehensive care for abortion. We welcome all the eminent speakers and guests to the CME. Now let us invite our beloved chief guest, Dr. Kasturi Donimath ma'am, Professor and HOD of Obstetrics and Gynecology Department, KIMS, Hubli, for inauguration.
Thank you, Dr. Aruna.
I request from Professor HOD Dr. S.R. Bidri ma'am to introduce Dr. Kasturi Donimath ma'am.
Good afternoon, everybody. It is my proud privilege to introduce Dr. Kasturi Donimath, my friend, Professor and HOD of KIMS Hubli, President of KASOGA, 2021, ex-Secretary General KASOGA, ex-President KASOGA, ex-President of Hubli Dharwad OBG Society, ex-Secretary General Hubli Dharwad OBG Society, co-investigator for international research projects, MC inspector to many colleges all over India, UG and PG exams at many universities, chairman of General Students General Activities KIMS Hubli, chairman of Graduation Committee KIMS Hubli, KOT trainer, faculty at many state, national and international conferences, conducted Jnana Harsha KASOGA PGCME for last 5 years, conducted many workshops, CME and conferences. I welcome you, madam.
Thank you, ma'am. Now I request Dr. Kasturi ma'am to say a few words regarding respectful abortion care and inaugurate the session.
Good evening, good afternoon, everyone. First of all, special thanks to Dr. Shailaja for such a nice introduction. First and foremost, I would like to extend my thanks to the patron of BLD Medical College and all the administrators of BLD Medical College. And my very special thanks to the organizing chairperson of today's webinar, Dr. Shailaja Bidri, HOD BLD Medical College, and President of Vijaypur OBGYN Society, Dr. S.R. Mudnur, Organizing Secretary, Dr. Rajeshwari Eliwal, and all the other members, and my special friend, Dr. Vidya Tobi, President-elect, KASOGA 23-24. Vijaypur is very close to my heart. I've been to Vijaypur many times. I've enjoyed the hospitality of all the members of Vijaypur, especially during, we always remember KASOGA conference, state level conference under the leadership of Dr. Vidya, Dr. Shailaja, Dr. Manpreet, Aruna, many more, Dr. Mudnur. So we really enjoyed the state conference. Now, today's topic on respectful abortion care is very, very relevant topic. It is really in need of the hour. It is very, very important to educate each and everyone, all the healthcare workers, all the doctors, and the gynecologists of respectful abortion care if we have to reduce the maternal morbidity and mortality. Actually, in the past, septic abortions were not very common. Actually, the things are much better now because 25 years back, when in our initial days of practice or during our post-graduation days, the kind of cases we used to see about this septic abortion, illegal abortion, it was really horrific. You know, I can just remember 1 or 2 incidences, many more every week we used to have. But one incident I cannot forget is one young lady, hardly she was 15 years, she was 28 weeks pregnant. She has not shown up to 28 weeks gestation and she has gone to a local quack. And that person, what he has put, you can't imagine what he has put in a uterus. He has put a sharp rod into a cervix, and that rod, and then that patient came with history of bleeding PB. When we examined, we saw that abdomen was distended totally. And then when we opened, can you imagine what was there? The baby was out of the uterus. There was a huge cut right from fundus to the cervix on the uterus, and the colon was hard, means 2 pieces of colon, means the way what he might have used, we just can't imagine what that quack had used to do an abortion during that time. And poor lady, yeah, small young girl, she has to stay in the hospital nearly 2 to 3 months with colostomy ban, everything, to recover. And one more case I really remember, she had come from Copper. She was only 13 years girl, and she had missed her periods. So this girl got this thing that it was an abortion. She was pregnant. So what she has done, she has gone to a local quack, and this another great fellow, I don't know what he has put something into her vagina, and she came to us with some leaking, water discharge, leaking of urine. So when we examined, when we put speculum, urine was leaking from the anterior vaginal wall, and there was a rent, So, and then when we saw, it was a bladder injury. And when we did a scan and did a urine pregnancy test and beta HCG, everything was negative. Poor 13-year-old girl, she was not even pregnant, and she has ended up in the wrong hands and got her bladder and ureter torn. So this kind of things we used to get in the past. Means in the past, there were lots of myths, superstitions, and misconceptions about abortion. They wanted to hide it. So they never used to go to a registered medical practitioner or gynecologist. They used to always, whenever they were pregnant, especially in the villages, they used to try to go to some local untrained person, quacks and all, and get into problems. So we used to have minimum 3-4 cases of such bad septic abortion cases in the past. But the scenario is much, much better now. People do come to the gynecologist and the registered medical practitioner. But the problem, what we are seeing with abortion is, the educated people, these young girls, they don't go to gynecologist, they go to a medical shop and ask for medical abortion tablets. So with that, what we are finding nowadays is, there'll be like very high gestational age and they'll have taken medical abortion. Or what the other thing is, the person, medical shop person will know whether it is ectopic or intrauterine, would have given the medical abortion tablet. And we have seen many cases. I still remember a case who ended up in our casualty, pulseless, BP-less, and she was ectopic pregnancy. When we asked the history, they told some quack had given them some medical abortion tablet, she has taken. So it was a totally ruptured ectopic pregnancy, totally in shock. Such cases we are seeing now. So this training of respectful abortion care is very, 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 very important to everyone, gynecologists, all the doctors, and all the healthcare workers, so that we can reduce the maternal morbidity and mortality. One more thing, why it is very, very important is, this will help in stabilization of the population. As we have achieved we may not have achieved 100% in everything in our country, but definitely we have achieved more than 100% in population growth. So we have to stabilize this population, and this training and education about contraception, along with going hand in hand with abortion, will definitely help in stabilization of the population. And this training will definitely achieve optimum standard of care at all levels. And because it's women-centric, yes, it is the need of the hour. And definitely this kind of training is going to make a lot of difference in the society. So I'm very happy that you have come up with this, and I wish you all the best. And you have eminent faculty for this. And I once again wish all the best. And thank you, BLD team, Parliament team, and Bijapur Obgyn Society for inviting me as a chief guest for this function. Thank you once again.
Thank you, ma'am, for your kind words of wisdom. Now I request Dr. Kasturi ma'am to inaugurate session.
Yes, we inaugurate this session. There is lighting of lamp. Yes. Yeah. We inaugurate this session with lighting of lamp by invoking Goddess Saraswati. Yes.
Thank you, ma'am. Today's CME shall start with the session on medical termination of pregnancy, an overview by Dr. Aruna Biradar, Associate Professor, Department of Obstetrics and Gynecology, BLDE Medical College, Deemed University. Now I request Senior Professors Dr. VR Gobur ma'am, Senior Consultant, and Dr. SR Bidri ma'am, Professor and HOD, Department of Obstetrics and Gynecology, BLDE Deemed University, to chair the session. Now, I would like to introduce our chairperson, Dr. VR Gobur. She is Professor of Obstetrics and Gynecology, BLD Medical College. Ma'am did her MBBS, MD Obstetrics and Gynecology, and MCB WIMS Bellary. Professor of Obstetrics and Gynecology, BLD Medical College. PG Guide and Examiner since 2003. Past President of Foxy Vijayapura. Faculty and Chairperson, and paper and poster presentations at various national and state conferences. Multiple publications at national and state conferences. Now I would like to introduce our next chairperson, Dr. SR Bidri ma'am, Professor and HOD, Department of Obstetrics and Gynecology, BLD Deemed University. MBBS, ma'am did her MBBS from JN Medical College, Belgavi, and MD from BLD Deemed University. Professor and HOD of Department of Obstetrics and Gynecology, BLD Deemed University. Worked in international project conducted in BLDE, conducted many health camps conducted by Inner Wheel Club of Vijayapura, awards Senior Scientist by BLDE Deemed University, Women in Science, and Best Doctor Award by Rotary Club of Bijapur. Now I would like to invite Dr. Aruna Biradar ma'am for her talk. Now I would like Dr. VR Gobur ma'am to introduce our speaker, Dr. Aruna ma'am.
Observe for 4 hours, analgesic, ibuprofen may be given.
Aruna Biradar is recovered from our own garden. She is a member of Sister MS ODC from there. She is a member of Foxy, Jaipur. Executive member of IMA, Vijaypura since 2003. Delivered various lectures on women's health. Presented many posters and papers at state and national conferences. Actively participated in UG curriculum formation. A coordinator of Department of Universities Value Added Programs. Department in charge for NAC criteria group. The member of Sports Committee. Co-investigator in cohort study and other WHO. Skills. High-risk pregnancy, publishing research articles related to OBG, infertility, and laparoscopy. Digital teaching for UGs and PGs. Here I present Dr.
Thank you for your kind words, ma'am. Today, good afternoon to one and all. I'm really thankful to the Foxy and the RAC team for giving me an opportunity to talk about the most sensational topic of today's society, that is abortion. Today, I'll be dealing with Medical Termination of Pregnancy Amendment 2021. The objective of this module, which I'll be speaking, is to take a closer look on what are the new laws and what are the changes in the laws. As we all know that unsafe abortions in India have become the major cause for maternal mortality, morbidity, and hamper women and girls' full participation. So according to WHO and today's world, 8% of the maternal deaths per year are mainly due to abortions, and it is the third leading cause of maternal mortality. Nearly 2 out of 3 of the abortions are performed by being unsafe, and nearly half of the pregnancy-related deaths in the women and in the girls under 24 years of age are due to unsafe abortions. According to WHO, when we call that the abortion is safe, abortion is
called safe, and it meets both the criteria, that is when the abortion is done by appropriate methods and is done by the trained persons. Whereas if one of the criteria is not met, that is, if it is done by an inappropriate method or untrained persons, it is called less safe. If both the criteria are absent, it is called as unsafe abortion. A medical termination of pregnancy amendment 2020 helps improve in the safe and comprehensive care which is mandated by law. The salient features of amendment 2021 MTP are, there are the modifications in the requirements which are provided to the customers or the consumers. That is, previously according to the MTP Act, the requirement of opinion of one provider for MTP was only up to 12 weeks, whereas for 12 to 20 weeks it was 2 opinions required. Whereas 2021 amendment, up to 20 weeks of gestation age, only one registered medical practitioner's opinion is required, whereas from 20 to 24 weeks of gestation age, 2 registered medical practitioners' opinion is required. The potential outcome of this revision of the amendment is that it helps in increasing the number of the facilities, especially in the public sector like PHCs, which are eligible for service provision up to 20 weeks of gestational age. The second amendment is, according to the previous Act, MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. But according to the new amendment, enhancement of the upper gestational age limit from 20 to 24 weeks of gestational age is for special or vulnerable categories of the woman, and it helps in further advancement for birth defects which are not compatible with life on medical board consensus, even if the gestation age is more. So the potential of this is it increases health access for vulnerable women to safe and legal abortion services, which are defined by the rules committee, including violence victims and minor, among others. The next amendment is for modification for birth defects and congenital anomalies. According to previous Act, the Act had provision for termination of such pregnancies only up to 20 weeks, whereas a new amendment, the upper gestational limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by the medical board. The potential is that it increases in access to safe and legal abortion services, who often seek services late beyond the legal limit for termination of pregnancies with substantial fetal anomalies which are diagnosed late, thus reducing the unsafe abortion and court cases. The another modification is it is related to the marital status. According to the previous Act, the condition of failure of contraceptive was applicable for only married woman or her husband. But according to the new amendment, the condition of failure of contraceptive to be extended is for any woman or her partner. The potential is that it increased access to safe and legal abortions for any woman irrespective of the marriage age, especially with upcoming changes in the legal age of marriage and improvement and advancement for increasing the access to safe abortions helps in reducing the unsafety. The next amendment is that insertion of new clause for strengthening the privacy. According to previous Act, the MTP Regulation 2003 mentioned that information should not be disclosed except under authority of law. Whereas the new insertion is name and other particulars of a woman whose pregnancy has been terminated should not be revealed except to a person authorized by any law for the time being in force. The potential is that the increase in the privacy and confidentiality of the abortion seeker increases demand but need to safeguard the rights and dignity of a woman and provided respectful bias-free services, including counseling and contraception. So the law salient features of MTP Amendment 2021 is that the name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being in force, and the ground of failure of contraception has been extended to woman or and her partner. The rules under MTP Amendment 2021 are categorized into special or vulnerable category of women, norms for the registered medical practitioners,
Powers and functions of the medical boards. The rules, a special category for women eligible for MTP between 20 and 24 weeks. We all know it, but still to mention, one is survivors of sexual assault, rape or incest, women with pregnancy in humanitarian settings, disaster and or emergency situations as declared by the government, change of marital status during the ongoing pregnancy, whether it is widowed or divorced, women with physical disabilities, that is major disability as per the criteria under the Disability Act, mentally ill women including mental retardation, minors, the fetal malformations that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. The norms for the registered medical practitioners defined as the old act as MBBS or more with any medical practitioner who have assisted 25 cases of MTP, of which at least 5 done independently in a hospital. Medical practitioners who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. And medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. According to newer amendment, up to 20 weeks of gestation, it is only one registered practitioner opinion. 20 to 24 weeks, it is 2 registered RMP's opinion. Beyond 24 weeks, it is a medical board opinion. Norms for the registered medical practitioner under the amendment rules 2021, an additional category of provider has been added. For termination up to 9 weeks with medical methods, RMP with experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by medical methods under supervision of an RMP in a hospital established or maintained or a training institution approved by the purpose for this purpose by the government. Rules under MTP Amendment 2021, the norms of RMP whose opinion is required for termination, as I told you, less than 20 weeks of gestational age, it is only one registered practitioner with experience of the above mentioned. For 20 weeks to 24 weeks, it is up to 12 weeks, sorry. It is up to 9 weeks, only one registered medical practitioner. Up to 12 weeks is also only one registered medical practitioner. 12 to 20 weeks is experience and training requirement for registered medical practitioner. It is post-graduation degree, 6 months of housemanship, and 1 year practice in obstetrics and gynecology. 20 to 24 weeks experience and training requirement for RMPs, post-graduate degree, 6 months housemanship, and again 1 year of practice in obstetrics and gynecology. But here, opinion of 2 registered medical practitioners is required. For beyond 24 weeks of gestational age, we need a medical board, that is opinion of medical board is required for termination of pregnancy, where it is advised by the medical board is carried out with all the safety precautions along with appropriate counseling at an approved place. One is that they should hold a degree of obstetrics and gynecology, or they should have at least 1 year practice in obstetrics and gynecology. Composition of the medical board should consist of a gynecologist, a pediatrician, and a radiologist or a sonologist. Powers of the medical boards. The power of the medical boards is to allow or deny termination of pregnancy beyond 24 weeks of gestational age only after due consideration, ensuring that the procedure would be safe for the woman at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. Cooperation with other specialties in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. To note that the FOXI with ministry guidelines and WHO support as part of RAC can operationalize and host medical board information on website. The functions of the medical boards is to examine the woman and her reports and who would approach for MTP, provide the opinion of medical board in Form D in regard to the termination of pregnancy or rejection of request for termination within 3 days
of receiving the request for MTP. To ensure that the termination procedure when advised by the medical board is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for MTP. So this is the new amendment or the changes which have been brought in the 2021 in the MTP law. Thank you.
Thank you. Thank you, ma'am, for your knowledgeable lecture. Now let's move on to second talk, Safe Abortion and Updates in Technology by Dr. Vidya Tobi, ma'am, Professor, Department of Obstetrics and Gynecology, Alamein Medical College, Vijayapura. Now I request Dr. S.R. Bigri, ma'am, to introduce our speaker, Dr. Vidya Tobi, ma'am.
My proud privilege to introduce Dr. Vidya Tobi, very close associate, Chairman of Food and Drug Medical Surgical Equipment Committee, Proxy 2018-20, Best Committee Proxy Award at Mero Hansotia 2020-20, ICOG Governing Council Member 2021-23, Proxy Chairman Award 2019, National Corresponding Editor Jogi, Organizing Chairperson Asoka 2016, President of Bijapur OBGYN Society 2009, Secretary Bijapur OBG Society 2007, publications in various books and contributions to Proxy. Focus and speaker in national and international conferences, papers at national and international conferences, organized various medical education workshops and awareness programs, advisory faculty of Board of Rajiv Gandhi University Health Sciences, post-graduation and undergraduate teacher for 30 years. I welcome you, madam. It is my great pleasure to introduce you. Thank you.
Thank you, Dr. Shaila, for those kind words. And I'm really privileged to be a part of this important safe abortion updates in technology. And I wholeheartedly congratulate our President Foxy, that is Dr. Shanta Kumari, and Dr. Madhuri Patel, who has taken this initiative to spread the knowledge about the respectful abortion care. So we were talking about respectful maternal care. Now the time has come to talk about respectful abortion care as well. So thank you, and I would like to share my screen. So kindly allow me to share my screen. Yes, hope I am able to share my screen and you people are seeing my screen. I am making it slideshow. Is it visible?
Yes, ma'am, it is visible.
Visible. Okay. Thank you very much. Let us start with the second module now, which is regarding the updates in the technology. We all know the, yeah, yes. What has happened?
Slideshow.
It has not come as a slideshow. Okay, I'll again stop and share. Yes, now?
No.
I don't know what has happened now.
Ma'am, the icon is at the bottom.
I'll go to the bottom. Okay.
Ma'am, the flashlight symbol is there, ma'am. Third one.
No, next, last one.
No, I clicked that only. For my laptop, it is seen as a slide share, but here I'll close it and again share. Okay.
Now it is coming.
Now it is coming. So now you can see the slide share, no?
Yes, ma'am.
Okay. So I'll start my talk. This is a module 2, and it is regarding safe abortion updates in technology. We are going to talk about, I am not here. I'm able to share my screen, and I'm very happy that the slides are moving and you're able to listen to me. So in this session, we are going to talk something about existing guidelines, pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. Now, WHO, we all know that there are various global guidelines on safe abortion. If you visit the WHO website, you will know what is the various guidelines have been there. You can go to the website and go through it. What we are interested is the nutshell, what we are going to follow here all over country and what is it about. So there are various WHO national publications on safe abortion, and recent one is about, that is on 2019, which is consolidated guidelines on self-care intervention for health. So it is just a roadmap to WHO safe abortion guidelines, right? So further, Dr. Aruna has beautifully explained you how the law had changed from 25th March 2021 to rules have changed on 24th September 2021, and it has appeared in the Gazette of India. So there are a lot many changes in our Medical Termination of Pregnancy Act, and it has been amended. So all of us, one should know the law when we are performing any abortions. All guidelines have three key areas in the management of abortion safely. One is always we talk of pre-abortion care. First one. Second is abortion care methods. And third and most important is aftercare and follow-up of including the post-abortion contraception and counseling. So always we forget about the aftercare and follow-up. We have to call these women again for the counseling, and we have to, at each visit, we have to counsel them about the contraception. So whenever a woman comes to you for any abortion, you have to take a thorough medical history, which is very, very important, which includes her menstrual history in detail. Then second comes the physical examination, the laboratory and other investigation if necessary and if they're available. They are not, all the investigations are not mandatory. Remember this. Then again, we're talking about the discussion on the contraceptive options. So always we have to maintain the confidentiality. We have to generate a faith. Always whenever we are talking with a woman, any person comes with the abortion, we think it otherwise. So we have to counsel her properly. She has to choose the right method of abortion, and she should always be allowed to choose amongst, means always it should be like a cafeteria approach. She might take a medical method, she may opt for surgical method. So you have to explain in detail what are the various methods available with you and what are the things, complications and follow-up. All these things should be told to her in a very nice way. So based on the duration of pregnancy, of course, and of course, her medical condition. So all these things you should keep in mind. Now, what is pre-abortion assessment and counseling? Now, we were talking about the detailed history. The history is very important. Her LMP is important. Her menstrual history, whether the cycles are regular, irregular, all those things are very important. I have to take a detailed history about that. Then comes the general physical and pelvic examination, which is also equally important, whether the patient has got additional any physical, means if she's obese, many times you will not be able to do proper pelvic examination, and properly you will not be able to assess the size of the uterus. These are the other factors. But in physical examination, you will know whether she is very pale. You can know about her any edema or any other conditions can point out to other medical disorders. So the general physical and pelvic examination is a must. Laboratory and other investigations, of course, will come in a further discussion what important investigations you are going to do. Now, the decision-making information on abortion procedures and counseling is very important. The patient is also a part of your decision making. Apart from it is always a clinician's decision, no doubt, but also we have to take account the patient's choices as well. Now, the gestational age determination by the last menstrual period or physical examination. We all know the pregnancy dating by physical examination. So, per abdominal examination, after 12 weeks gestation, the uterus rises out of the pelvis. It is palpable. All these points, all of us know, but we have to examine her properly. And we also should know the limitation to the dating by uterine size on physical examination. We all know that uterine fibroids, multiple gestation, marked retroversion, or obesity or molar pregnancy. Definitely there is a disparity between the size of the uterus and your examination point. So this also matters a lot. So we know that the uterus is smaller than the expected, may indicate the woman is not pregnant. It can be inaccurate menstrual dating, or it can be ectopic pregnancy or abnormal intrauterine pregnancy. So these things one should remember. If the uterus is larger than the expected, then it may indicate the again inaccurate menstrual dating. Her dates might be wrong, or it can be a multiple gestation or uterine abnormalities such as fibroid, again a molar pregnancy. So these things we should remember when there is a disparity in the examination. Now, now here what they say is pre-abortion investigation. So routine lab tests are not a prerequisite for any abortion services, mind well. The test that may be performed as individual risk factors on findings of physical examination. So clinician has to decide what investigation should be are mandatory. So pregnancy test, if the pregnancy is unconfirmed, you are finding that she's not pregnant, but she's telling there is a period of amenorrhea, she has come to you for abortions. So pregnancy test, when the pregnancy test is to be done if pregnancy is unconfirmed. Second is a hemoglobin or hematocrit if you are suspecting anemia. RH testing is mandatory if RH immunoglobulin is available for RH negative woman. HIV testing and counseling should be done for this woman. STI screening usually performed during pelvic examination if you suspect any infections. Other laboratory tests as indicated by medical history, like if you are suspecting some kidney or liver function test. Ultrasound is not necessary. There are a lot many debates on that, unless to diagnose, you want to diagnose pregnancy, or if you're not certain of you're suspecting ectopics or missed abortion. In these women, you have to do ultrasound. But all of us, we know that we do ultrasound because we want to know confirmed if the sac is there or where it is. Now, about the counseling, which is a very important part, you have to ask, you have to inform, and you have to document. Three parts you should remember whenever you are counseling a woman. So you have to ask thoughts about the termination of the pregnancy. Whenever a woman comes, what are the reasons for termination? What things she wants to know? What are her fears and complexes? So we have to talk with the woman in a very friendly manner. Secondly, you have to tell her that early abortion is safe. Importance of a trained provider performing the procedure for safety. We all know the problems of over-the-counter availability of the abortion pills. We are all fighting for that. But even then, some of the periphery, we also know the quacks having this. So we have to stress on this woman that she has to go for the trained provider for this for this performing the procedure for safety. What are the various available methods of abortion should be told to her, risk and the warning signs associated with the abortion methods, and without contraception, she can get pregnant as soon as 14 days after abortion. So every abortion, you have to counsel her for contraception. Resumption of her normal activities, including sexual intercourse, should be told, and any other follow-up care should be told to her. Now, what about the documentation? Everything you have to take in consent, the decision to accept post-abortion contraception to be noted. But Even if she is not willing for contraception, she should be provided with the abortion services. This is again mandatory. Many times we counsel and we tell her, no, 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 if you are not taking any contraception, I am not going to provide any abortion services. So this is a wrong part, because they may go to the quacks, they may land up with in many problems. So better to give abortion services and counsel her properly for the post-abortion contraception, so that she will come back to you again. Now, what are the clinical management of abortion? So abortion care less than 12 weeks, what are the global recommendation? One is mifepristone and misoprostol. Second is misoprostol only. Third is vacuum aspiration. If the gestation is more than 12 weeks, mifepristone and misoprostol, and dilatation and evacuation. And which is not recommended is dilatation and sharp curettage. Unless the products of conception are very, very adherent, then only you can use this sharp curettage. Otherwise, sharp curettage is not at all recommended. Now, clinical management of abortion, we talk of three types, means medical methods, methods of means and surgical methods. These are manual vacuum aspiration or evacuation by vacuum aspiration. So these are the two methods for the surgical evacuation. Now, when we talk of medical methods of abortion, the tablets which we are using are mifepristone and misoprostol. We all know that mifepristone is an anti-progestin, inhibits the action of progesterone. It interferes with the continuation of pregnancy, and initial oral mifepristone is followed by misoprostol, which is prostaglandin E1 analog. So misoprostol causes cervical softening, uterine contractions, and expulsion of products of conception. Now, what are the advantages? We all know, I will not go into the detail of the advantages of tablet misoprostol. The protocols for mifepristone and misoprostol, which are commonly used. On day 1, we are giving mifepristone 200 milligram orally. And if she is Rh negative, give anti-D 50 micrograms. Then day 3, mifepristone on the day 3 of mifepristone administration, up to 7 weeks, we give 400 microgram of misoprostol, 2 tablets of 200 micrograms each, sublingual, buccal, vaginal, or oral. Or if she's from 7 to 9 weeks, 9 weeks means 63 days, that is what the limit is. 800 micrograms sublingual, buccal, vaginal. In addition, we have to give some analgesic, antiemetic, and you have to offer in this visit only contraception. The analgesic, which is most commonly used, is ibuprofen. You can use simple paracetamol as well. Within day 15, follow-up day, that is a follow-up day, you have to confirm and ensure the completion of procedure, offer contraception if not already done so. So what I feel is many times we get the MTP kit and the whole MTP kit is being given to the patient. Please don't do that. You have to call this woman again on day 3 and day 15 for the confirmation, ensure means completion of the procedure, and of course the counseling for the contraception. What are the characteristics of different routes of misoprostol administration for the first trimester abortions? If oral means you are giving the misoprostol and these pills are swallowed, and they recommended up to 7 weeks, up to 49 days for the first trimester abortion. The side effects, always we know about these side effects, that diarrhea, nausea, fever, and chills, which are always treated symptomatically. The buccal route, the pills are placed between the gums and cheek and swallowed after 30 minutes. Here we get more patients, means they the side effects like fever, chills rather than vaginal route. Sublingual, the pills are placed under the tongue and swallowed again after 30 minutes. Usually they get absorbed. There are increased incidences of fever, chills, diarrhea, and vomitings compared to the vaginal route. And this is a fastest onset of action and highest plasma concentration levels we get with the sublingual. In vaginal, the pills are placed in the vaginal fornices at the deepest portions of the vagina, and the woman is instructed to lie down for 30 minutes. The pill fragments may be visible, of course, and the lowest rate of side effects with the vaginal route. Now, this is how the buccal and sublingual routes of misoprostol administration. This is a picture, you can just remember this. Now, these are the various WHO drug regimes and dosage schedules for the medical abortions and the recommendations. The combination regime, which is the recommended one, that is mifepristone, and after that is a third day, that is a misoprostol. So mifepristone, we give 200, already this is a repetition again, 200 milligram per orally once, and misoprostol 800 microgram buccally per vaginally or sublingually you can give. Or there are misoprostol alternative regimes, 800 microgram buccally per vaginally or sublingually every 3 to 4 hours. Now you can expect vaginal bleeding for 2 weeks after this, which is normal after medical abortion. You have to counsel again about this, and such bleeding can last up to 45 days in some of the rare cases. Now, the provision of these medical abortion services, the services should be available at the primary care level with, this is very important, referral systems in place for all required higher level care. So additional services may need to be provided in individuals seeking medical abortions. One is counseling and testing for sexually transmitted infections, HIV, then abuse support services, and most important, psychological or social services, and other specialist health or medical services. So these referral additional services are required. We have to provide iron tablets for anemia if required, then provide any necessary pain medications, and most important is the emotional support if needed. Now, whenever we talk of follow-up care, routine follow-up care, not necessary following an uncomplicated medical abortion using mifepristone or misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any other medical concern. And routine follow-up visit is recommended only in case of medical abortions using misoprostol alone to assess the success of or completion of abortion. And you have to assess the woman's recovery, ask for any signs and symptoms of ongoing pregnancy. Sometimes the patient won't abort, then we have to ask her to get one ultrasound, check ultrasound. And if the pregnancy, you find out the pregnancy is continuing, then you have to tell her that the complication what she can have if she has consumed misoprostol. We know the various anomalies she may get, so she has to abort this pregnancy. Review any available medical records and referral documents, ask about any symptoms experienced since procedure, perform a focused physical examination for any other complaints she has, and assess the woman's fertility goals and need for the contraceptive services. If you have not talked about this, you have not provided, you have to provide them. Now, this is a summary one should remember. What to do? One is physical and pelvic examination. Confirm the eligibility. So up to 49 days, 7 weeks of LMP, you have to give mifepristone 200 milligram orally first day. Offer NTD 50 micrograms to RH negative woman. Tell the woman to return for the misoprostol administration after 2 days. Contact the address and phone numbers of the facility. You have to give this to the woman if she has got any complications or any emergency. And you have to tell what are the emergencies. Means she has got excessive bleeding, excessive pain, she has to contact immediately. Record her experience of any side effects on MMA card. That is medical abortion card. You have to provide that card, and on that you have to write all the experience, what she has got, any side effects of any tablets. Now remember that 3% of the women may expel completely with mifepristone alone, but misoprostol schedule should be completed. That is very important. Then when she comes for the second visit, that is day 3, give misoprostol 400 micrograms sublingually, buccally, vaginally, and orally. Observe for 4 hours in the hospital. You may have to give additional analgesics like ibuprofen, 400 milligram. Contraceptive option should be told to her and this visit as well. Mean period of bleeding can be 8 to 13 days. You have to tell to woman, and these are the possible side effects of the tablets you should you should tell what are the possible side effects, and you have to ask her to report in case of excessive bleeding, pain, abdomen, and fever, and report if there is no bleeding even after 24 hours after misoprostol. Consider giving additional dose of misoprostol. 75% of the women they abort within 4 to 6 hours after misoprostol administration. Then second thing is what to do on day 15. So pelvic examination should be done to ensure the completion of abortion. You have to give again contraception option like hormonal methods, condoms, or IUCD, or sterilization after one menstrual cycle. And tell the woman about immediate return to fertility within 14 days if she doesn't use any contraception backup. Report back if there are no periods within 6 weeks, and if of completion of the abortion process. Ultrasound is mandatory only if the examination does not confirm the completion of procedure. Now, these are the very important, and you should know about the side effects and complications of these medical methods. One is very much pain, and it can be a non-judgmental communication. So you have to explain that she might experience some sort of pain. You have to give verbal support, adequate counseling. Then you can give analgesics like ibuprofen. If the pain persists with failure to respond to these drugs, several hours warrants the evaluation for other cause. It can be ectopic pregnancy, infection, or incomplete abortion. Nausea and vomiting is usually self-limiting. You have to reassure. Diarrhea is also self-limiting. Again, limiting. You have to reassure. Infection is you have to confirm by physical examination. And if you suspect infection, you have to start antibiotics. Routinely, they don't advise routine antibiotics after medical methods. Now, action for failure or incomplete result, you have to, if there is a failure of medical methods, you have to offer vacuum aspiration, or you can also repeat medical methods, like you can give additional dosages of misoprostol. If there is incomplete results, you have to observe unless heavy bleeding. If the bleeding is resolved, uterus comes to normal size, you just say that it is abortion is complete, and you have to confirm by ultrasound if required. Then if again you can repeat misoprostol, or in these patients, if you suspect incomplete results, you have to offer surgical methods. Now, if the patient or woman present with excessive bleeding PV, bleeding more than her menstrual cycle, which is soaking 2 pads in 1 hour or 2 consecutive hours, and you have to observe this bleeding. If bleeding decreases over time, then if it is bleeding decreases, you have to follow the routine care, keep a watch on her vitals. Bleeding PV, she can go home. If bleeding continues, watch for the vital signs. PV, do pervaginal examination. There are products of conception in the cervical canal. You can do digital evacuation. The woman becomes stable, bleeding reduces. Then again, you can say, observe her for 1 more hour, check her vital signs and bleeding, send her home. If the bleeding continues, then your ultrasound is indicated. Minimal decidual beats, wait and watch. Then products of conception and decidual beats, woman is stable. You can repeat misoprostol 600 microgram orally or 400 sublingually. Then watch for any expulsions. If woman is not stable, there are decidual beats, better to go for vacuum aspiration, and then complete the procedure. The recording and reporting is also important, since medical methods also come under the purview of MTP Act. So documentation is similar to that is required for the vacuum aspiration procedure. It is mandatory to fill all the forms. Remember this. Form number C is consent form. Form number 1 is RMP form. That form 2 is monthly reporting form, and form 3 is admission register to the case records. I have already shared these forms in our Bijapur OBGYN Society group. You can go through this. This is mandatory for medical methods as well. Now, about the surgical methods, of abortions. These are the vacuum aspiration, which is a recommended technique for surgical abortion of pregnancies up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method, and this procedure should not be routinely completed by sharp curettage. The vacuum aspiration methods, we all know this vacuum aspiration, um, manual vacuum aspiration kit. It has got a handheld aspirator which is used to generate vacuum. Okay. So I think my cursor is not moving. We have, if everybody is able to see this, it has got a plunger handle. Here is the collar stop, retaining cap, and here the various wall buttons are there, right? So it has got a handheld aspirator. It generates the vacuum. The aspirator is attached to the cannula of 4 to 12 millimeters in diameter, and these cannula can be used in multiple settings, including those without electricity. That is an advantage. So IPAS or easy grip cannula size correspond with the weeks of gestation. 8 millimeter cannula can be used for 8 weeks and 10 millimeter cannula for 10 weeks. So it has got various apertures here, and it has got a wing base. So it is just nicely fits here. Okay. There are electric vacuum aspiration cannulas also. There are also disposable plastic cannulas, and an electric pump is used to generate the vacuum. It can accommodate cannula of a manual vacuum aspiration with correct size tubings. Now, what about the cervical priming? It may be considered for women with pregnancy of any gestational age to prepare the cervix and make soft and easy to dilate. The recommended methods, we all know that we use oral mifepristone 200 milligram 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 micrograms administered vaginally 3 hours prior to the procedure. The laminaria tent that can be placed intracervically 6 to 24 hours prior to the procedure. Now, nobody used these laminarias, but long ago, we used to use them. They used to swell. So we used to put it in the cervical canal around 24 hours prior. But these are the various nice methods have come up, and these are the routinely used by all of us. Now, pain management plan for a vacuum aspiration procedure. The important component of quality abortion care is we have to comfort these women and counsel them. And definitely 2 components of pain management you can try. That is, one is non-pharmacological and pharmacological. Pharmacological, of course, is use of medication. Now, non-pharmacological is very important. Psychological support, explain each step to the woman in advance, what you are going to do, what can happen to the women are very anxious because this is a vacuum aspiration, can be just OPD procedure many times. We used to have a separate room for this vacuum aspiration procedure, and the procedure should be performed very gently and smoothly. You have to encourage this woman to relax and breathe deeply, because we know that once the cannula is put in the cervical canal, many women, they have vasovagal attack. So we have to first one take the woman in confidence, and you have to counsel her properly about the procedure, the complications and everything. Don't tell too many complications. So the patient will go into so many psychological stress, and they may land up with many problems. Now, these are the various pharmacological pain management. You can give anxiolytic like diazepam 10 milligram orally 1 hour prior to the procedure, or you can give slowly 2 to 5 milligram 20 minutes prior to the procedure. Now, the duration of effect of diazepam is around 4 to 6 hours, and the side effects, we know that patient can have disorientation and dizziness. And actually, whenever these procedures are performed by the side of your OPD, many times we don't have standby anesthesiologist or anybody. So we are doing your procedure at periphery. So we have to do it very properly. Okay. If you want a general anesthesia, definitely you have to shift these procedures should be done in the OT, and definitely you have a help of your anesthesiologist. The cervical dilatation, you can give local anesthesia with lignocaine. That lignocaine is 10 ml, 1% lignocaine at around, we give at 4 and 8 o'clock direction that you have to inject. And the duration again 60 to 90 minutes. You have to aspirate and see that you have not entered any blood vessels, definitely. And the side effects are dizziness, sometimes seizures, and with analgesic, the patient develops gastritis. We all know that if you are giving on empty stomach 400 to 800 milligram of ibuprofen, definitely the woman has gastritis. So these are the side effects. If the patient has uterine cramping in this post-operatively, or definitely we can give ibuprofen, but 1 hour prior to the procedure also you can try 400 to 800 milligram of ibuprofen can be given, and its duration again lasts for 4 to 6 hours. Now these are the steps of MVA. How to prepare the instrument. So you have to close the valve button, create the vacuum. You have to just pull up the piston and create a vacuum. Second is ensure the pain control medication, as we have already told, it should be given at the appropriate time. Give some time them to act. Ask the woman to empty her bladder, perform the antiseptic preparation, administer the paracervical block, dilate the cervix. Many times the dilatation is done by the cannula itself. So just to put the cannula very slowly and till fundus. Then you have to withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity. Then you have to release the vacuum button on the aspirator, rotate the cannula from 10 to 2 o'clock position with a smooth, gentle motion. You have to move the cannula so that everything aspirates in the aspirator. Signs that uterus is empty, all of us know that red pink foam without the tissue passing through the cannula, gritty sensation, and cervix gripping over the cannula, uterus contracting around the cannula. There is an increased uterine cramping. So these are the signs that uterus is empty. Then the most important is inspect the tissue and proceed with the contraception. Simultaneously, you can do IUCD insertion. And if the patient is willing for sterilization, you have to do this procedure in operation theater itself. So instrument processing, instruments has to be soaked in chlorine solution 0.5%, which assists the disinfection and it helps the tissue and body fluid. So this is very important. Now, the post-procedure care, monitor her for any complications and provide the management as needed. She may leave the facility if she's stable and meets the criteria for the discharge, which are important. Vital should be stable. There should not be any complaints from the patient and no bleeding. So ensure that the woman has all necessary information, medication prior to the leaving the facility. Document all the outcomes of the treatment, including any adverse effects, events in the facility register, as well as in the client record card. And aftercare, management of abortion complications like incomplete abortion, infection, bleeding, and ongoing pregnancy. The second important is provision of, again, contraception, contraceptive information, and offer contraceptive counseling and methods, assessment of any other sexual and reproductive health needs that may require additional care. So any point of time, these two things are very important. You are giving the services. Additionally, you should extend your services like contraception as well as sexual and reproductive health needs. The follow-up, no routine follow-up unless meso alone regime is used. This is a new recommendation from Foxy, that whenever you're using only meso or any WHO also, they say that meso usually you have to follow this patient and you have to call them for follow-up. So in summary, India has made a historic progress in improving access to the safe abortion. Not much has changed in the technological update in the last decade, so the methods remain the same. As providers, it is up to us, that is to ensure safety and quality, especially in the context of the amended law. So along with the safety, also we need to focus on respectful abortion services. So which is very important, and I think this topic is very greatly and aptly will be covered by Dr. Manpreet. and every client, public or private, an opportunity to inform, educate, and equip with the proper information on contraception and counseling. Now, contraception and counseling is also another topic which will be dealt with very clearly later. So one should always take care of our patients in a great way. So for this, registration and pre-test, post-test feedback are very, very important, and the certificates will be awarded to the participants on attending the training and submission of registration, pre-test, post-test, and feedback, which are very important. So don't leave. So after the completion of whole training procedure, a pop-up window will come. You have to add and you have to take a post test. After that only your certificate will be issued to you. I thank Dr. Shailaja Bidri as well as Dr. Gabur Madam for chairing the session, and Bijapur OBGYN Society for giving me the opportunity. Thank you, Foxy, and let us take care of our women and let us provide safe abortion services. For any of the queries, you can contact me directly because time is running short. Thank you very much.
Thank you, ma'am, for your
For your more informative talk on abortion. Thank you very much.
Now the session is open for questions. Thank you.
For Aruna madam. Medical board, who should form the medical?
Now I request our chairpersons, Dr. S.R. Bidri ma'am and Dr. V.R. Gopal.
According to what was discussed in the RAC training was that the state medical board should be formed at the state level. Now it is up to the states to either give directions to the districts to form their individual board or they will form a single state. So what we have put forward is that if there is a single state board, it will take a lot of time for us to reach the state board, get their opinion and get the patient back. So still the discussions are still on the table as to most probably they'll be asking the district headquarters to form the board. The DC will be in charge, the DSO will be within, and as they said, one HOD of the medical college, gynecologist from district hospital, pediatrician and minimum.
Thank you, ma'am. Now I request our chairpersons to hand over bouquet to Dr. Aruna Biradar ma'am and Dr. Vidya Tobi ma'am.
Thank you, thank you. I'm receiving through virtually. Virtual bouquet I'm receiving.
Give the flowers here only.
Namaste. Thank you. Thank you very much.
Elected as a Kasoga 2022.
Thank you very much. Thank you. Thank you very much.
Thank you, ma'am. Now I request Dr. Shobha Shiraguru ma'am to hand over the bouquet to our chairperson, Dr. S.R. Bidri ma'am and Dr. V.R. Gopal ma'am as a gesture of gratitude.
Now let's move to the second talk. Next session, I would now like to request Dr. Manpreet Kaur, Professor, Department of OBG, Alamin Medical College, to deliver lecture on WHO Seva Toolkit. I request Dr. Shobha Shirugur Ma'am, Associate Professor, Department of Obstetrics Gynecology, BLDE, and Dr. Rajeshri Elwal Ma'am, Professor, Department of Obstetrics Gynecology, BLDE, to chair the session. Dr. Shobha Shirugur Ma'am, MBBS, DGO, DNB, published in national and international journals, reviewed 2 original articles in various journals, and presented papers and posters in state and national conferences. Invited has a faculty in national, state conferences and regional conferences. Special training in ultrasound in pregnancy, laparoscopy, and infertility. Areas of interest: teaching, high-risk pregnancy management. Dr. Rajeshri Elwal Ma'am, MBBS, MS, Obstetric Gynecology, FICOG, Professor, Department of Obstetric Gynecology, Sri B.M. Patel Medical College and Research Center, Vijaypura, Karnataka. Ma'am presented papers in national and state conferences, many publications in national and international journals, faculty and organizer for various regional, state, and international conferences. Prize for presentation in Kasoga 2009 and 2016. Yuva Foxy 2004, associated with international research in rural Vijaypura, delivered many public awareness talks on PPH in rural Vijaypura and numerous talks on menstrual hygiene, management in schools of Vijaypura, radio talks, etc. Reviewed 5 international journals, including IJOG, IJWH, and Helion. Society, Honorable Secretary of Bijapur Obstetric Gynecology Society, State Committee member of IMA, Vijaypura, member of Youth Red Cross, Adolescent Health Committee member, Kasoga. Now I request Dr. Rajeshri Elwal Ma'am to introduce Dr. Manpreet Kaur.
Thank you, Dr. Vishnupriya. It gives me great pleasure to introduce Dr. Manpreet Kaur, who is Professor at the Department of Academic Medical Science. She is very active academician and she has been chairperson of PASS Committee, IMA, Karnataka State. She has teaching experience of 21 years and has been teaching undergraduates and postgraduates in both PID Medical College, Alamin Medical College, and the district hospital. She is former head of the department of the PID section of the district hospital, Vijaypura. She has done operations in DDM management and in advanced ultrasound. She is certified menopause practitioner and she has many publications and presentations to her credit. She also has a menopause research project on her areas of interest are high-risk pregnancy, infertility, fetal medicine, and menopause management. Over to you, madam. Thank you very much, chairpersons, for introducing me. Very good afternoon to everybody. I'm thankful to BLD University to Alameen Medical College and Bijapur Obiji Society for having given me this opportunity to be here. Because as Aruna Madam said in the beginning, now this is a hot topic of discussion, and this act which has come in 21, it has come as a big sigh of relief, I think, for all the obstetricians, gynecologists, as well as the patients, because so many times we used to feel helpless in the face of situations where we direly needed to help our patients, but we could not because our hands were tied because of the law. So now this is going to go on for the next 2 or 3 months, and we are going to be going on talking about 2021 Act and RAC especially, because unless and until I'll talk about RAC and all, I'm also thankful, let me go ahead, I'm also thankful to Foxy, RAC and WHO for having given me this opportunity to be a master trainer for TOTs. I'll begin with my talk, but before I talk about RAC, that is the WHO Saver Kit, I think. Yeah, safe abortion values, evidence, rights, and respect. So when I first heard about the Saver Kit, I thought it's a kit just like the eclampsia kit, which contains drugs like misoprostol and mifepristone, and then we are going to be talking about all those things again. But no, Saver is SA is safe abortion, V is values, E is ethics, and R is rights and respect. So these are the 4 words that really have to be emphasized, because now let me just give you an overview of this talk. I'm not going to be talking about doses. I'm not going to be talking about drugs. I'm not going to be talking about who can do what, under what circumstances, up to how many weeks. What I'm going to be talking about is what we should have here when we encounter a patient who has come for abortion, and what we should have on our tongues when we talk to a patient, and also what we should not have in our minds or try not to have on our minds, because I cannot dictate what you people think and you cannot dictate what I think. So, but there is, in case there is an attitude which I feel may not be very friendly towards an abortion in any patient, there is scope for change. Because so many times now, recently, I have been guilty of, the thing that I'm going to be talking about now in this talk. And there was a patient who had just got married 3 months back, and they had come with 2 months of amenorrhea. They wanted an abortion. And I, like a, granny sort of a obstetrician, I said, no, why do you want to abort your first baby? What if you have infertility and all? I mean, I gave her all the negative things under the sun, and I did not finally give her the abortion kit that she had come to me for. And later on, yes, definitely after attending this training, I did feel that was not really fair. After all, if my counseling is not really acting, then give the patient what she wants, because it's not an easy decision for any woman to finally decide to abort, especially for a first baby. So when they come to us, I really don't know what is forcing her, or I cannot be in her shoes. So what I can give her is a lot of empathy. I can give her help. I can give her counseling. I have to be friendly to her, and later on finally give her what she's come for, and that is professional opinion and help. Okay, so the module aims to define respectful abortion care. Now, RAC, as Madam said, I think Toby Ma'am said, RAC has been formulated on the same guidelines as RMC. We are aware of what RMC is? Respectful maternity care. Are you aware of what happens in respectful maternity care? This is for the PGs, of course. See now, do you know that now one attender per laboring woman is allowed during her labor as well as during the time of delivery inside the labor room? Initially, what we were doing, we were just showing out the relatives. No, go out now, she's delivering. But now even the husband with permission can be allowed inside, and that is number one. That is friendly maternal care. And second is that we do not shout at the patient. She is not bearing down, that's okay. We do not slap her, we do not pinch her, we don't tell her she is useless, and we don't tell her that why did she have to come and deliver. Sometimes, yes, in the heat of the moment, these words have come to many of our mouths, but this is not what is supposed to be done. So on the same lines to respectful abortion care. Now, when you have seen a second trimester abortion, most of us have seen, it is quite distressing to the patient. And at some time, especially primaries, they really have a bad time with their pains. One is their anxiety, and the second is the physical pain. And then, yes, we have been guilty of scolding them and telling them that this is too much. So many people come and so many women abort. What is, you are no different. And also, RAC means this should not be our attitude, or this should not be the attitude that we bring out in front of the patient. This is all the talk is about. So it's not, it's a little abstract talk, it's a subjective talk, it's nothing objective. So you just have to sit back and listen. There are 3 videos in this, so I can also sit back and look at the videos. Now, so respectful abortion care is the concept which has come in after RMC, and RMC has become a global concept now with a lot of data which has gone from India. And shortly in the next few months and the next few years, we expect that RAC also will become a global concept. Now, we have to highlight how norms and stigma affect services. We know what a stigma. Unmarried girls becoming pregnant is a stigma. It's a big taboo. Unmarried girl coming to be for say an MT people becomes a big, talk of the clinic or the hospital. This is a stigma. We are no longer going to be talking about patients in terms of stigma, or no, we are only talking about patients who are in need of the right type of care, right advice in a friendly environment and in a safe environment. And finally, provided the WHO saver resources for respectful abortion care. Saver resources is they've given us some websites where you can go on net and just play 1 or 2 games, that will give you an idea about your own attitudes. I was surprised at how caveman type attitudes I had on some of the questions that they were presenting. And I realized that, yes, we have to change. See, there is an opportunity for change in everybody at any age. And it's better if we change earlier, because we are more moldable when we are earlier. And once you come to our age, it becomes a little difficult. But yes, change can be brought in and inculcated in every one of us. Now, I'll just take a moment to just give a gist of what has happened. The law has changed, and dissemination needs association and OB-GYN sports. This law by itself is not going to move itself. This law needs healthcare providers. And if healthcare providers are not patient friendly, healthcare providers are always negative. Healthcare providers are insulting the patients and trying to foster our thoughts on the patient. This law will not help any woman who needs help. If I keep scolding my abortion patients, next time what will she come? What will she do? She won't come to me. She'll go to the chemist and say, oh, give me those tablets, I'll take it at home. Yes, so this is where we lose a patient. So implementation of the new law has to have good positive support from all the healthcare providers. And that is where our work is really important. It's not the chemist or the nurse or the DAI can give that MTP kit. It's how, are they supposed to be giving those? Are they the RMPs, which the law has mentioned? No. So that abortion becomes a unsafe abortion. It becomes an illegal abortion. So we want that any woman who comes for an abortion should have a legal, safe abortion. And for that, our attitudes make a lot of difference. Now, Foxy is the largest provider base for abortion care because it has all the obstetricians and gynecologists. Online training has become so easy and possible now because of COVID. Thanks to COVID, most of us, all of us have become quite tech savvy. Initially, it was only the younger generation, and now we also know a little bit of, the mic is not working, the camera is not working, and all those things. Okay. Now, medical management of abortion uptake has increased, of course. And the best part of it is that there is no PCP and DT conflation because we do it only up to 9 weeks. Now, patient safety, respect, and quality matters more than ever. We have a role to play in all these. Now, what is respectful abortion care? It has been adopted from respectful maternity care recommended by WHO. Respectful abortion care refers to care that maintains the safety, dignity, confidentiality, ensures freedom from harm and mistreatment, I'll come to that, and enables informed consent and continuous support during and after all types of abortion. That is the fourth topic we'll be talking about. Once a patient is aborted, we don't say, okay, bye, tata. come only if you have a problem. No, we have to either follow her after 15 days if MMA, or we have to follow her after next month. She cannot be left alone on her own with her own doubts and uncertainties. So you have to give all this in as a part of RAC, respectful abortion care. In simpler terms, respectful abortion care means that you as a provider or a patient, if I go as a patient for one of these things, I have the right to be treated with dignity. Nobody can shout at me. Nobody can tell me, hey, you are coming again and again, get lost, I'm not doing all this. No, no one can. As a doctor, I cannot say that to my patients. Empathy. Stand in her shoes and think what she must be going through, or what all her problems was, what socioeconomic status she's come from, what problems she would have faced to, finally decide to abort this baby. And compassion regardless of your race, ethnicity, gender, socioeconomic status, or reproductive histories. Now, if you ever feel that something isn't right, speak up. This has been taught to us throughout since school times and at home also. And as a health professional, it is our duty to listen and support. Listen to your patients, hear them out, and then talk. Communication is the key. Now, what are the norms and stigmas? Now, here is a short video that you might find interesting. They are going to discuss norms. What do I mean when I say this is the norm in our society? It is a norm in our society that girls should wear decent clothes. It's a norm in our society that boys will go out and work and women will take care of them. So these are the things which the society says is okay, and we have sort of imbibed it into ourselves and we have accepted them. So it's just a video that we will play and see. Sorry.
Madam, we can see the video, but we can't hear the audio, madam.
Sriman, can you guide her how to unlock it or what to do?
Madam, this is Sriman.
What is the problem?
Madam.
Yes.
This is Sriman, madam. We can see the video, but we can't hear the audio, madam. The thing is,
we'll just take care of that. Just a minute. Audio is not showing.
No, video is not showing.
They are not hearing.
Video is not showing.
Are you seeing the video or you're not seeing the
Yes,
video?
madam. We can see only the video, but not the audio. We can't hear anything.
Audio
The
share.
video.
Okay. That's right.
Sir, we can't hear you here, sir. Still.
Now can you hear us?
No, ma'am. Stop playing the video, ma'am.
Please stop playing the video. We're not playing the video now. We're trying to clear this problem. Sir, I think it could be an isolated case because the others are able to hear it in their systems. Are you able to hear the video in the systems? Sir, there must be a problem with your, could you please check that?
No, madam. While sharing the video, you'll have and two check-ins at the left side. Share with audio. If you click on the check-in box, then we can see the video and audio also.
Okay. I have to go to the previous slide.
So go to share screen option, sir.
Wait, what, sir? Hello? Hello?
Yes, sir. Go to share screen option, sir.
Yeah, it is there. I'm there only.
In the left side, you'll find two check-in boxes, sir. Left side down. You have to select the audio settings.
Yeah. You know?
Hello, Priyankur.
So stop playing the video, go back and then start sharing again, sir.
Share हो गया है. Please stop sharing the video.
Yes, you're doing it.
And or culture in which
Yes,
they
sir.
are found.
Now we can hear.
People's behavior
Okay, can you hear now, sir?
Yes, we can hear you.
also change accordingly. What are some examples of social norms? Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, An unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Okay, so this was the first video. Now, stigma and norms perpetuate disrespect and abuse. I would rather read the left side column first. Now, every woman has a right to have freedom from harm and ill treatment. She has a right to information protection under laws like MTP and POCSO, informed consent and refusal, and respect for choices, preferences, dignity, and quality of care. Now, please remember that if at the time that procedure, either by us or by one of our subordinates or our seniors or the people who are working in our facilities, there is physical abuse by of the patient, like slapping, intimidating physically, or there is verbal abuse, or there is sexual abuse of a needful patient who comes to a healthcare provider, these are all violations of the woman's rights. Then stigma and discrimination, this we will be seeing in the saver videos. Also, besides the three abuses that we already know about, these are the three abuses which have not been very much talked about. Failure to meet professional standards of care. If I don't do it and I feel that I'm not equipped enough to deal with the patient and I don't refer her to another person who is better at me in handling that patient, this is also a violation of her rights. And it is a violation of the Hippocratic Oath. Poor rapport between patient and providers. You just don't talk to the patient, you just keep writing a prescription, tell her, go take it. That is not right. And health system conditions and constraints. So these are all the 7 types of abuse that we can face when we are, that the woman can face when she comes to us. So we should know that we are not supposed to violate any of these rights of the woman. Now, domains of respectful abortion care. What should we do? The woman should be free from harm and mistreatment. We should maintain her privacy and confidentiality. We should maintain her dignity. We should give her the cafeteria method of contraception. We should give her the methods of all the methods of abortion, and we should respect her choices. She may not listen to you. She may have already made up her mind as to what she wants. You explain it to her nicely and patiently. She doesn't agree with it, it's okay. Then engaging with effective communication. These are the soft skills that now I think the PGs also have been, they are being taught about this, and we are talking about this, and there are so many role plays that we do for PG teaching for the soft skills. Then providing information and seeking informed consent from the patient, ensuring continuous access to support, very, very important. Enhancing quality of physical environment and resources, dirty labor room, dirty beds, and there are vermin around the rooms. This is not where a patient is supposed to be taken care of, and this is against the law, frankly. Then providing equitable abortion care. The rich and the poor get the same treatment and the same attitudes as each other. Availability of competent and motivated providers. We should not only be knowledgeable, we should also be motivated that this patient who has come to me should get the best out of me as possible. Provision of contraception advice and commodity security and continuity of care and counseling, as we have already discussed before. Now it is time to strengthen the implementation. I will not go into the details because we've already talked about this. One provider for up to 20, 22, 24, 2 providers, and more than 24, any anomaly which is not compatible with ex utero existence. We need a medical board for that. But how to implement this? Unless and until you are, again, I said, you give respectful abortion care to your patient, you understand her, you support her throughout the crisis that she is going through, this law will not be implemented. So it depends on all the healthcare providers at all the levels, RMPs, doctors, specialists, MBBS, PGs. We need to work on our RAC to be able to strengthen the implementation of this beautiful law, which is a huge step forward for all women and for all the obstetricians and gynecists and RMPs of the country. Again, this is a video. We'll just have a short look at what it says. Avoid stigmatizing language. Don't talk in terms where the patient feels so embarrassed.
How to talk about abortion. A guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, how to talk about abortion. A guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal. How to talk about abortion. A guide phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Madam, we can't hear the audio, ma'am.
Yes, it is not audible.
Okay. So in this game that crossed the line, there are questions. Like it's okay for a woman to be slapped at home if she makes a mistake. So in this game, you have to either agree, disagree, or strongly disagree. Then there is a question that all women have the right to seek all types of abortion in our country. Again, agree, disagree. So this is the sort of questions that you can assess your attitudes, that whether I'm, what am I thinking, and whether what I'm thinking is considered right by WHO, or whether it is considered right legally or not. Then there is one more, the personal compass, which has questions like, a married woman has the right to make decisions about her fertility, even if her husband disagrees. Do we agree with that? Are we taking husband's consent nowadays? No, why? Because this consent is considered to be sexual coercion of the woman. So the woman need not take the husband's consent. She's okay. If she's a major, she can give her own consent. So this is what the saver kit consists of. Next. Now, we have come from the 1970s, where there were unsafe abortions, to the 2000s, which said safe abortions, and finally in 2020s, it is safe but respectful abortion care. Now, here are a few recap questions for all of us to think about. According to the WHO, access reduces the number of unsafe abortions. Yes or no? Access to abortion reduces the number of unsafe abortions. Yes, it is true. And safe is both criteria met, appropriate methods, trained person. Less safe is only one criteria met, and unsafe is neither a safe place and nor a trained person. Then the MTP Amendment Act 2021 requires a minor less than 18 obtain written consent from the parents and guardians before she can undergo a termination of pregnancy. True or false? She is underage, she is less than 18, she needs a parent or a guardian's consent. False. The 2021 says that any person accompanying a woman, a girl who's under 18, can give consent provided that person is above 18. And you verify his or her age by Aadhaar if you want to. Okay, so now it is no longer needed that an unmarried girl coming to me has to get a parent or guardian, and most of the times you see that we lose patients like that. Nobody wants to see if she's having, say, a pregnancy which is before marriage or something. She doesn't want a parent or guardian to be brought along and signed and all. So now you need not have a parent and guardian to give consent, except if she is underage. What is important? I will give her the abortion. I have to do the abortion because I am legally bound by this act. But what else I should do? POXCO. You have to inform the police that such and such case is there. There is an underage pregnancy, and they will follow their own rules and whatever they have to do. Your work is over. Your work is giving her a safe abortion because you're a trained person, counseling, support throughout the process, and information to the police, whatever the system is, or to the person. For example, in Alameen, we inform the CMO, and the CMO proceeds with informing the local ladies only police station or whatever is done. Okay, so yes. See, you and I are not concerned with the emergency right now. As of now, a girl has come, a woman has come to you for abortion. Yes, then definitely comes an emergency. That you and I are not going to be part of it. That procedure has to be followed. You cannot not inform. Now, please remember that in case you do not inform the police about protection of children from sexual offences, we all are can be given imprisonment up to 6 months and or a fine. So this has to be done. Information to the police has to be done. Underage girl becoming pregnant, but you cannot say, no, I will not give you abortion, because definitely she will go and try to get it done from an unsafe person. And not only do we have a very young child becoming pregnant, we also have a maternal mortality. Can you imagine that unsafe abortions is the third most commonest cause of maternal mortality in India still? So it's, it's high time that we reduced at least this part. We can give safe abortions. We have the methods. We have the intelligentsia. We have all the trained people. We just have to implement this and win the patient's confidence that yes, we are going to do it for you. Don't worry, we are there. Okay, 30-year-old woman, recently widows, wants an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. No, we don't. She's her choice. Up to 24, we can legally abort. It's her choice. She wants to terminate. Yes, we are going to be there to help her out. Up to 24 weeks, we can do for this lady. Okay, so in India, abortion is legal. Let it make it safe and respectful is what the whole gist of this long drawn out talk. I came here from home. I thought, let me not have interruptions, but somehow we had all these interruptions. So I'm sorry for that. And technical will have to, become better and better, I think, with more webinars. So I think questions at the end of or now? Any questions? Thank you.
Thank you, ma'am, for your informative talk. I would now request Dr. Sangami Smartpati sir, Associate Professor, Department of Obstetric Gynecology, BLD, to deliver lecture on pre and post-abortion family planning. I request Dr. Shobha Shirgur, ma'am, Associate Professor, Department of Obstetric Gynecology, BLD, to introduce our speaker.
Sandesh sir does not need any introduction. Already he is very popular among post-graduates. Sir completed 30 years to be a part of medical college, and sir did his DO from Bangalore Medical College and MD from Vijayanagar Institute of Medical School. He has completed his fellowship in basic and advanced laparoscopy from Lifeline Hospital, Kerala. And he is a skilled lab coordinator in BLD Medical College, and he is also a BOS member. He has worked as core committee member for organizing 27th Kasoga, and he has given many guest lectures. He is also a sub-investigator for WHO international projects like Action 1 Trial, Action 2 Trials, and he is mainly interested in infertility and laparoscopy. And over to you, sir.
Thank you, ma'am, for the kind introduction. Friends, it's from good afternoon to good evening now. So I know you all are exhausted. We'll quickly go through the slides, and the main topic is today we have come to a stage calling it, termination as a respectful. Earlier, it was just a medical terminology. It was just a medical care, which is required or not required. These two things. Now it is not only medical; it is emotional, social, and economical issue also. So today I'll be dealing with the pre and post abortion family planning counseling, and also a quick word on the leveraging the technology for referrals and online consultations. Okay, what is counseling? Technically, counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. It's not just providing an information to the client, it's just about interaction up with them, listening to them, understanding them, and then conveying the right method for the patients or the clients. Now, why we need a pre and post abortion? We call it as peri-abortal counseling. Now, it is an integral part of comprehensive abortion service. It is not just a formality. It is as important as the procedure itself. And the woman will be needing your help during the decision making. So, whenever the spouse, whenever needed, the spouse should also be counseled. So, it is not just that we tell a woman that this is the method you abort, you go, and you take the contraceptive method. So whenever required, both the partners has to be counseled, conveyed all the information required. Now, why we do need a pre-procedure counseling? Like pre-procedure counseling is regarding family planning, like contraception methods or family planning methods, because a woman needs your help to decide about the termination of pregnancy, whether it is really needed or not needed. Then woman also needs her help to choose the method of termination. Then ensures to deliver a complete information of the procedure, because most of the people think that you take a tablet and abortion will be done. So that's not the case. You have to convey them the entire procedure, the duration required, everything. And then she also needs your help to adapt a contraceptive method after the abortion is completed. Now, what we do in a pre-procedure counseling, we ensure a privacy and confidentiality, as we are stressing upon the act that it is a respectful termination and conception for the lady. So it should be private and confidentiality so that she will be free to communicate. It should not be it should be non-judgmental, and you should be sensitive enough. Like we do get many unmarried women coming for termination, and the still getting married, engaged couples come to us for the termination of pregnancy. In those cases, we should not judge them, or we should not comment anything about their personal life. Then we should have an establishment of rapport with them. So we should communicate in a such a way. Instead of talking only the points, we should just develop who are you, what's, and introduce yourself. So they feel comfortable talking to you, establish a rapport, then use simple language and allow the woman to clarify her doubts. Like in educated patients, you can tell that this is the medication, this is the pill, this you do. For rural people also, they do deserve a respectful termination of pregnancy and contraception. For them, you should use a local language, communicate to them in their language, and also they will have some rituals and myths regarding the termination. We should clarify them under their local languages. Then after that, she has made up her mind for termination of her pregnancy, assess her for the procedure. Now, why we do need a peri-abortal counseling for the family planning in case of medical termination of pregnancy? Because it's not like the lactation period where around 10 weeks the patient won't get a fertility. It is a quick return of fertility. Second, most important, it is the opportunity when the acceptance for contraception is more. And next thing is, it's always advisable to have a next pregnancy at least 6 months after the termination of pregnancy. Next thing is health benefits, better future pregnancy outcomes, because she might be having a termination because of certain genetic disorders or deficiency of certain minerals. So we may have to assess her health, provide her the required services, care, and the next pregnancy outcome would be good. So we need time. For that, we need a contraception. What they observed that 90% of the abortion related to maternal mortality can be prevented by ensuring contraception. It is not just delaying for the namesake, it is for understanding and treating the underlying causes which has led to the termination of pregnancy. Now, when to do a pre-abortion family planning counseling? First visit, when the patient comes to you For a termination, you have to do the counseling for family planning. I'm talking about family planning. The decision has to be made, has already made that she has to be terminated. Second is exceptions like grief management. There is a delay in contraception. Like a patient really wants a child and she has come to you, like an elderly primary has come to you and you say that you have to terminate because of a chromosomal abnormality. She is not accepting the thing that it is to be aborted. And that time you don't tell that, okay, you abort and have a contraception method. First you terminate it, let her pass through this procedure. After she recovers from the grief, counsel her for the contraception. This is just to tell that every time it doesn't associated with termination followed by contraception. Now what we have to counsel? That we have to counsel that once the termination is over, the fertility is going to return very quick. That is within 10 days to 4 weeks. Help her with the choices, she can select from the basket of available contraceptive methods. Method specific counseling. Once she selects a counseling method, contraceptive method, you counsel regarding that method. And high risk behavior, like those who are elderly, those who are having ill habits, or any medical conditions where the contraceptive method is contraindicated, those things also has to be discussed with the couple. Now, the most important, if the woman is not willing for any contraceptive method, do not refuse the MTP. Like we get many patients, we have 4 to 5 females, and this time she comes and says that I want an abortion. I will see whether to have a contraception method or later or not. We say that you get an tuberculosis, then only will do MTP. So this mentality has to go. It is her right to have a termination. We have to provide her the services. Try and counsel her after the procedure. Now, what we were talking is pre-abortal counseling for the family planning. Try and counsel her after the procedure. If she is still not willing, call for follow-up in weeks and re-counsel her. Now, once she terminates and she has come to you, like she might have undergone a MTP done at some center and come to you for a contraceptive method. What we have to do? We have to ensure that the abortion process is complete. She might have taken a medical termination process, MTP, or she might have undergone a surgical also, but still the process might be incomplete. There should not be any existing infection following the procedure. So we ensure that there is no infection. There is no injury to genital organs. So far, many of our seniors have explained regarding the horrifying experiences where many females have undergone illegal abortions and they came to you with injuries. So we ensure that those injuries are not there. And chances of fresh pregnancies are ruled out. Like she aborted around 1.5 to 2 months back, and she has come to you for contraception. Make sure that now she is already not pregnant. Okay. So after the procedure of MTP, we go for post-procedure counseling. We ensure the woman has understood the precautions and care needed during the post-abortion period. This is an opportunity to counsel for contraception in case not previously accepted. Like as we said, pre-abortion, we have counseled her for contraception. She has not accepted. But now she has come back. We can use as an opportunity to counsel her. Reinforce the need of continuing the use of contraceptive method chosen. Like if it is one of the failure, it is resulted out of a failure of contraception and she had conceived. Then we counsel her that she has to continue. She said that, okay, I had used this method, I failed and conceived. So I don't want to use it. So we have to counsel her that there is some protocol to be followed. If it is properly used, this has less chances of failure. So continue to use whatever contraceptive method you were using earlier. So what the post-procedure counseling involves? Continue to see, first thing, continue to ensure privacy and confidentiality. As we discussed earlier, even after the abortion, her confidentiality and privacy has to be ensured. Reassure her in case of any problem. If she has a minor medical issues or any queries, assure that you are available for her to treat them and manage those conditions. Repeat the information about post-procedure care and danger signs. Even if you are offering her contraceptive method, tell her in case she continues to bleed, she continues to come with the fever, maybe turned into septic abortion. So we have to counsel about the entire procedure. Now, what to do when the patient comes after the abortion if they are already using one method of contraception and they come for your medical advice? You appreciate, you tell that, yes, right, you are doing right by using the contraceptive. Some people may say that I had an abortion 1 month back and I started using the contraceptive. Is it safe or not? Am I doing right or not? So you should appreciate and tell them, yes, you are doing right. But only thing is all the protocols has to be followed there. like when the tablet has to be taken, if it is OCPs, what to be done whenever the IUCDs are used, and follow the protocol. Just means whatever the things to be done, you have to tell about the contraceptive method. In case she has not decided about the contraceptive method, post-abortion she has come to you, what you should do? Allay the anxiety. You tell that it is safe to use a contraceptive method post-abortion. Nothing is going to hammer your fertility for the future. Then importance of immediate adoption and choice. Like I want to take a contraceptive method after 2 months, but meanwhile you may get pregnant. So you should tell that as early as possible, you should adopt one of the methods of contraception. Extended period of adoption, couple counseling is required. So as I said, it's better to counsel both the couples, so the couple itself, rather than counseling the lady. And also they say one word about emergency contraceptive pills. If she had an abortion, went back home, had a sexual activity in the last 1.5 months, and then she realized that no, I want a contraception, and come to you. So you should also tell that before opting for a proper contraceptive method, there may be need for emergency contraceptive pills also. So that also has to be emphasized to the couple. Now, just quickly, most of you know all these things. I'll just go through what are the possible methods available for a post-abortive contraception. One is barrier methods. In first and second trimester, they have divided. As soon as sexual activity is resumed, it can be used in first trimester, and the same in the second trimester. The advantages are there is no hormonal side effect, can be used without consulting a health provider, easy available, and as usual, provides protection against sexually transmitted diseases. And most importantly, it enables the man's responsibility for the contraception. Second one is IUCDs. In the first trimester abortions, inserted immediately or up to 12 days after the confirmation of a complete abortion using the surgical method. If you are following a medical method of abortion, it should be inserted around day 15 of the procedure, provided complete products of conceptions are expelled and risk of presence of any infection or any other contraindications for the IUCD are ruled out. If you are following the second trimester, we'll be usually doing a surgical method. So can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. So you can use an IUCD. What are the additional information you have to provide for the couple is that it is highly effective, provides long-term contraception. It can be used by any person trained, doctors, ANMs, TPC, IUCD trained doctors, and after the second trimester abortions. There is no interference with the sexual activity, immediate return to the fertility on removal, and there is no hormonal side effects. Now, regarding using the combined oral contraceptive pills, if it's first trimester abortion, immediately or up to 7 days after the abortion, when you are using the surgical method. If you are using the medical method of abortion, it can be started on day 3. As earlier discussed, on day 3, we are going to give misoprostol. So with that dose of misoprostol or within 15 days of the procedure after confirmation of complete abortion. So oral contraceptive pills can be started in the first trimester abortion, post-abortion in this way. If it is a second trimester MTP, immediately or up to 7 days after the abortion. Now what are the other things, important aspects of this method is, it regulates the menstrual cycle, can be provided by all healthcare workers after the first screening by trained providers, no interference with the sexual activity, offer protection against ectopic pregnancy, endometrial and ovarian cancers, and also benign disease of the breast. It's not suitable for women who are breastfeeding babies less than 6 months old. So whenever you are using a combined oral contraceptive pill, it contains estrogens in interference with the lactation. So it's not suitable for the lactational ladies, the lactating ladies. So next one is the long-term injectables or medroxyprogesterone acetate. Again, it can be given immediately. The injections can be given immediately or within 7 days following a surgical method. If it is medical method of abortion, it can be started on day 3 with the dosage of the misoprostol as COCs. If it is second trimester, immediately or up to 7 days after the abortion. The salient features are it's highly effective, confidentiality and privacy is maintained. It's just a shot, they take and they go back. Then can be provided by any trained personnel or healthcare provider. It doesn't interfere with the sexual activity. No effect on the quality and quantity of the breast milk. That's more important. If lactating woman can also offer this method of contraception. There is no estrogenic side effects. Offers protection against ectopic ovarian cancers, iron deficiency anemia, uterine fibroids. Now the permanent ones, a female sterilization. If it's first trimester MTB, most of our patients come with this. They want a permanent method and they undergo MTP and they undergo sterilization. It can be performed after an abortion in the absence of any infection or severe blood loss, concurrently or up to 7 days, both mini-lap and laparoscopy. This we have to stress here. If it is first trimester, we can do a laparoscopic sterilization also. Can be done. If it is medical method, it can be done only after the first menstrual cycle. Okay. Then second trimester, if it is there, mini-lap sterilization can be performed concurrently or up to 7 days after the abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended if it is second trimester MTP. The salient points of this method is permanent method of contraception, highly effective immediately, no influence with sexual activity or breastfeeding, no long-term side effects, offers protection against ovarian cancer. Vasectomy performed on males independent of the timing and procedure of the abortion. It's a very effective permanent method of contraception. No, as usual, no interference with the sexual activity or long-term health risks. But one thing, as usual, we have to counsel the couple regarding using of any other contraceptive methods for the first 3 months after the vasectomy. This is just a graphical representation of whatever we have explained so far. Now, quickly about the sexually reproductive health services and teleconsultation and utilization of any other technologies. Now, leveraging technology, that means utilization of the available technologies in doing a teleconsultation, counseling, guidance, reference, and linkage. So these are the available tools for utilization of technology for counseling or consulting the popular people regarding the contraception. We have websites like Hamdo, social medias like YouTube, infographics, helplines available by the national and international bodies. And also we have websites by the government and WHO where it can be utilized to guide the couple. What is the SWOT analysis for the teleconsultation? What is the strength of this method is, in the COVID era, when the proper person-to-person counseling or consultation is not required, it is a very useful tool. It's approachable throughout the process, confidence, awareness, spread out questions, answers at ease. The weakness is there is no face-to-face consultation, and we can't demonstrate certain graphs and modules to the couple. Opportunity is the privacy and comfort is better. It is a cost saving and number of visits are cut down if you are doing a teleconsultation. The threat is missed opportunities. Everybody is not accessible to these teleconsultations, and also misdiagnosis. There may not be a proper communication between the patient and the doctor, so we may miss some of the aspects. So what is the role of this teleconsultation? Yes, we can use this method for confirmation of diagnosis and contraceptive need. We can use many video conferences and Zoom links like what we are doing now. And we can give a hybrid services. Sometimes once they can come back and visit us, and then they go back and communicate us through a teleconsultation, and all the information then can be given to the patient. What is the key message? Realize the need of peri-abortal family planning. So what we need is, it's not just about terminating the pregnancy, what has to be done after that. It needs a proper method of contraception for at least 6 months. Bring the couple on board and strive for 100% coverage. So all the couples should have counseling for the contraception method post-abortion. Capitalize on basket and applicability on peri-abortal period. So offer them all the methods available and allow them to choose it. Technology as far as possible, scope for entry into comprehensive abortion care services. There is concern regarding policy, malpractice, service cost and access. This is regarding the technology. It is advantageous, but sometimes we may have problems using the telecommunication in these services. Adolescent reproductive health needs both online and offline counseling. Thank you. It was. Well, I thank Foxy and the RAC team for providing an opportunity to have an interaction with you. Thank you.
Thank you, sir. Now the session is open for discussion. Thank you, sir, for the lecture.
Thank you, sir, for your insightful words. Now I request Dr. Rajeshri Elwal ma'am to hand over bouquet to Dr. Manpreet Kaur ma'am. I request Dr. Shobha ma'am to hand over bouquet to Dr. Sangamesh Mansur. Now I request Dr. Sridevi Kori ma'am to hand over bouquet to Dr. Rajeshri Aliwal ma'am and Dr. Shobha ma'am as that token of respect.
Thank you, ma'am. Thank you everyone for making this evening a bliss by sharing your valuable time and knowledge with us. Now I request Dr. Rajeshri Eliwal ma'am to give vote of thanks.
As we come to the end of this session, which has been quite an extensive discussion on respectful abortion care, many of the old concepts I think have been cleared, especially on the respectfulness regarding the abortion. Many of our speakers have spoken about the new changes in the MTP Act, and a couple of things which I noted specifically were that it's a woman's right and woman's choice to have an abortion. We need not enforce our thoughts on the abortion, which we do traditionally do as gynecologists. So that is out. And the other important thing was that the woman need not opt for permanent sterilization or any contraception after abortion. So these are the two things which I felt were very important in this session. So I would like to thank Foxy for giving Bijapur Ubiji Society this wonderful opportunity to take part in this wonderful program that is respectful abortion care. I would like to thank Shanta Kumar madam and Madhuri Patel madam for giving us this opportunity. I'd also like to thank the BLD University patrons, Dr. M.B. Patil sir, our Vice Chancellor Dr. R.S. Mudhar sir, Registrar Ambedkar sir, and our beloved Principal Dr. Arvind Patil sir, who have given this opportunity to conduct this program in a hybrid mode. I'd also like to thank our observer of the day, Dr. Sriman Kumar sir, who has been with us throughout the session. I'd like to thank our speakers and chairpersons who have done a wonderful job. And I would also like to thank Dr. Jay, who has been coordinating all these sessions and responding to all our phone calls and emails. I would like to thank our young and energetic staff from the OBG department, Dr. Basuraj Patil, who was the IT coordinator, and Dr. Sridevi Kori and Dr. Preeti Malpure, who was managing the catering, and our postgraduate students. Our postgraduate students who are some are on screen and some are behind the screen doing a lot of work for this CME. At last, I would like to thank our sponsors who sponsor us even at a very, very short notice. That is Mr. Vikas Marathi and Mr. Raghavendra Patil from Protocols and Pharmaceuticals. Thank you.
Please fill up the feedback feedback forms.
Yeah, I
please.
need to come in for a minute here.
Yeah, please come in, Ajay.
Yeah,
It is
because
required.
Vidya, you were mentioning the point about filling up the post-test and feedback, because I
Yes.
don't want going forward emails coming from you that we don't have it.
Yeah, and we need the certificates. Yeah, please.
Yeah.
So everyone has to fill the feedback forms so that you will get the certificates.